After 24 hours, resuming normal activities. After 24 hours following a cesarean birth, several normal functions return, and women are able to participate more actively in their own care as follows. Both the indwelling catheter and the IV line are usually discontinued. The dressing, if present, is removed in 24 hours. Staples, if present, are removed before discharge. Steri-strips, small strips of adhesive, may be placed over the incision when staples are removed. A small nonstick dressing may be placed over the incision to protect it from friction from clothing or adipose tissue, or the incision may be left open to air. The woman is helped to ambulate by the first postpartum day and is comfortable sitting in a chair for brief periods. Clear liquids are changed to a soft or regular diet when bowel sounds are audible or the woman is passing flatus. In some agencies, solids are provided earlier. Nurses should encourage the woman to increase her activity and ambulation each postpartum day. By the second day, she is usually allowed to shower. Preventing abdominal distension. Abdominal distension is a major source of discomfort. Measures to prevent or minimize it include the following: early, frequent ambulation, tightening and relaxing the abdominal muscles, avoidance of carbonated beverages and the use of straws, which increase the accumulation of intestinal gas, pelvic lifts, lying supine with her knees bent. The woman lifts her pelvis from the bed and repeats the exercise up to 10 times, several times each day. Simethicone as ordered to help disperse upper gastrointestinal flatulence. Rectal suppositories is ordered to help stimulate peristalsis and passage of flatus. Teaching for discharge. After cesarean births, mothers receive the same overall teaching as those who had vaginal births. Information about care of the incision and signs to report to the healthcare provider are added. In addition, women should have support at home because they are recovering from major surgery as well as childbirth. Application of the nursing process. Knowledge of self-care. Assessment. Regardless of the method of birth, nurses are responsible for providing health education before the family is discharged from the birth facility. Much should be taught during this short time, which is not ideal for teaching mothers who are not fully recovered from the birth process. Before beginning teaching, determine the learning needs and major concerns of the family. Multiparas remember some aspects of self-care, but often benefit from a review. Primiparas may be anxious about self-care measures and all aspects of infant care. They may need more thorough teaching and more time for practice. Identify the effects of the most common barriers to learning. Age and developmental level, cultural factors, and difficulty understanding the language. Identification of patient problems. In general, women adapt well to the physiologic changes after childbirth, and most nursing care is wellness-oriented. A common patient problem is a lack of knowledge of personal care, signs of complications, and preventative measures. Planning. Expected outcomes. Expected outcomes for this problem are that the woman will do the following: verbalize or demonstrate understanding of self-care instructions by discharge. Verbalize understanding of practices that promote maternal health by discharge. Describe plans for follow-up care and signs and symptoms that should be reported to the healthcare provider by discharge. Interventions. Preparing for teaching. Before beginning teaching sessions, be sure the woman is comfortable. Give pain medication if needed. Schedule the teaching in such a way that it does not interfere with meals, infant care, needs, or visiting. Make a teaching plan with the woman to include topics most important to her. Identifying the woman's educational needs ensures her interest in the topic selected and makes best use of the short time available. Topics of less interest may require just a brief review. The review may elicit questions from the mother and interest in more in-depth information. Teaching about the process of involution. Provide the woman with basic information about involution, including how to assess lochia and locate and palpate the fundus. This information allows her to recognize abnormal signs such as prolonged lochia, reappearance of bright red lochia after lochia rubra has ended, and uterine tenderness, which should be reported to the healthcare provider. If the mother is a young adolescent, another family member also may need the information. Teaching self-care. Hand washing. Emphasize the importance of thoroughly washing her hands before the woman touches her breast, after diaper changes, after bladder and bowel elimination, before and after handling peripads, and always before handling the infant. Observing nurses model this behavior reinforces the teaching for parents. Breast care for lactating mothers. Instruct the breastfeeding mother to avoid using soap on her nipples because it will remove the natural lubrication secreted by the Montgomery's glands. Keeping the nipples dry between feedings helps prevent tissue damage, and wearing a good bra provides necessary support as breast size increases. Measures to suppress lactation. If the mother chooses not to breastfeed, initiate measures to minimize lactation and increase the mother's comfort. Techniques such as binding the breasts, applying an infrared lamp, fluid and diet restrictions, external application of jasmine flower, and ice packs have all been used to suppress lactation without convincing evidence. Current recommendations include instructing the woman to wear a firm bra 24 hours a day and express only a small amount of milk if absolutely necessary for pain relief. The woman may use cold compresses or gel packs inside the bra for comfort. Cold cabbage leaves also promote comfort. They should be washed and dried. The large lumpy veins should be cut out or rolled flat with a rolling pin. The cabbage leaves should then be refrigerated. The woman should place the chilled leaves in her bra and change them out every 2 hours or as they become limp. Analgesic medications may be recommended by the provider. Care of the Cesarean incision. If the birth was by cesarean, the woman may have concerns about care of the incision. Staples, if used, are usually removed before the woman is discharged. The obese woman may go home with staples and have them removed by the healthcare provider after discharge. If adhesive strips have been applied over the incision, teach the woman that she can shower with them in place and that they will gradually detach. If a topical skin adhesive was applied in surgery instead of staples or adhesive strips, there is no dressing, and the woman is generally allowed to shower. For each method, explain that the incision is closed and is unlikely to come apart. There should be little or no drainage from the incision. Instruct her to call her provider if the incision separates or drainage increases or has a foul odor. Perineal care. Teach the woman how to clean her perineum. The most common method is to fill a squeeze bottle with warm water and spray the perineal area from the front toward the back. Remind the new mother not to separate the labia during this procedure to avoid allowing water to enter the vagina. The tip of the bottle should not touch the perineum. Toilet paper or moist antiseptic towelettes are used in a patting motion to dry the perineum. Teach the mother to dry from front to back to prevent fecal contamination of the vaginal introitus from the anal area. She should perform perineal cleansing and change peripads after voiding or defecation. Some women do not use peripads for menstrual protection and should be taught how to use them correctly. Panties and adhering pads are used in most facilities. Careful handling to avoid contamination of the pads is important to prevent perennial infection. Thorough hand washing is a must before and after changing pads. Unused pads should be stored inside their packages. Pads should be applied without touching the side that comes into contact with the perineum. The pads should be applied and removed in a front-to-back direction to prevent contamination of the vagina and the perineum. Used pads should be wrapped and disposed of in a covered container. Kegel exercises. All women should be familiar with Kegel exercises. These movements strengthen the muscles that surround the vagina and urinary meatus. The exercise helps prevent the loss of muscle tone that can occur after childbirth and may decrease urinary incontinence. Promoting rest and sleep. Many women experience fatigue after childbirth that continues for weeks or months. Women are often tired when they begin the postpartum period because they slept poorly during the third trimester and are further exhausted by the exertion of labor. Feelings of excitement and euphoria after childbirth interfere with rest. Numerous visitors and phone calls, hospital routines, noise, frequent interruptions, and an unfamiliar environment also interfere with rest. After pains, discomfort from an episiotomy or incision, muscle aches, and breast engorgement, swelling from the increased blood flow, edema, and presence of milk, further contribute to a woman's discomfort and inability to sleep. Most mothers are discharged from the facility within 24 to 48 hours after the vaginal birth or 72 to 96 hours after cesarean birth, and they go home with a tremendous deficit in sleep and energy. Yet new parents may be unprepared for the conflict between their need for sleep and the infant's need for care and attention. A telephone call to screen mothers for prolonged postpartum fatigue may be helpful in the days after discharge. Anemia, infection, and thyroid dysfunction also may cause postpartum fatigue. Women at risk for these conditions or suffering postpartum fatigue after the first 2 weeks Be evaluated and treated if necessary. Rest at the birth facility. Hospital routines continue around the clock, making undisturbed rest difficult to obtain during the birth facility stay. Make every effort to avoid interruptions and allow mothers adequate time for unbroken rest periods and relaxed time with their infants. Cluster assessments and care and try to correlate them with times when the mother will be awake, such as just before or after meals, infant feeding times, and visiting hours. Make plans with the mother for napping. Suggest you restrict phone calls and visitors during planned nap times. Encourage the mother to use a side lying position for breastfeeding to allow her to rest during feedings. Quiet, softly lit environment also promotes sleep. Rest at home. Help the mother understand the impact her physical discomfort and the demands of the newborn and other family members will have on her energy during the first few weeks. If she understands that fatigue is normal and will continue for some time, she can plan ways to obtain extra help and conserve her energy. Suggest energy saving measures such as the following: maintain a relaxed, flexible routine that focuses on care of the mother and infant. Nap or rest when the infant sleeps. Plan simple meals and flexible meal times. Limit visitors. Accept assistance with food shopping, meal preparation, laundry, and housework. Ask family or friends to care for the infant to provide nap times for the mother. Put off housework that is not absolutely necessary. Postpone major household projects. Involve friends and family to provide care for other children. Avoid heavy meals or vigorous exercise near bedtime. Advise the mother to restrict intake of caffeine to use caffeine-free versions for the first few weeks. Suggest relaxation exercises, lying quietly, alternately tightening and relaxing the muscles of the neck, shoulders, arms, legs, and feet when a nap is not possible. Emphasize to the mother the importance of asking for help when she begins to feel exhausted or overwhelmed. Encourage her to share these feelings with a partner, other family members, friends, and other new mothers. Infant sleep and feeding schedules. Many families require information about infant sleep cycles, frequency of feeding, and probable crying episodes during the first few weeks. Although newborns sleep much of the time, they may awaken every 2 to 3 hours for feeding. If possible, having the father or another helper assist with nighttime care of the infant allows the mother longer sleep periods. For the breastfeeding mother, this would mean that the helper gets up, changes the baby's diaper, brings the baby to the mother to nurse, and returns the baby to the crib or bassinet after nursing. Providing nutrition counseling. Food supply. Low-income families might benefit from referral to government-sponsored programs such as Temporary Assistance for Needy Families, TANF, or the Special Supplemental Nutrition Program for Women, Infants, and Children, WIC. Determining the facilities available for cooking and storing foods also may be necessary. The new family may need referral to a social worker to identify the best solutions for their unique problem. Diet. Although many women are unsatisfied with slow weight loss, they should avoid severe restriction of caloric intake. A balanced, low-fat diet with adequate protein, complex carbohydrates, fruits, and vegetables provides the energy and nutrients needed. Promoting regular bowel elimination. Explain the role of progressive exercise, adequate fluid, and dietary fiber in preventing constipation. Walking is an excellent exercise, and the distance can be increased as strength and endurance increase. Drinking at least 8 glasses of water daily helps maintain normal bowel elimination. Unpeeled fruits and vegetables are high in fiber, and prunes are natural laxatives. Additional fiber is found in whole grain cereals, bread, and pasta. A regular schedule of bowel elimination is important in overcoming constipation. For example, bowel elimination after breakfast allows the mother to take advantage of the gastrocolic reflex, stimulation of peristalsis induced in the colon when food is consumed on an empty stomach. Measures that reduce perineal and hemorrhoid pain include witch hazel astringent compresses and hydrocortisone ointments, which also facilitate bowel elimination. Promoting good body mechanics. Exercise. Exercise has beneficial physical and physiological effects during the postpartum period. Teach exercises in the early postpartum period to strengthen the abdominal muscles and firm the waist. These mild exercises can be started soon after childbirth with 5 repetitions twice a day. The number of exercises increase gradually as the mother gains strength. Exercise routines may be resumed gradually after pregnancy as soon as medically safe, depending on the mode of delivery, vaginal or cesarean, and the presence or absence of medical or surgical complications. Some women are capable of resuming physical activities within days of delivery. In the absence of medical or surgical complications, rapid resumption of these activities has not been found to result in adverse effects. Pelvic floor exercise could be initiated in the immediate postpartum period. Walking is a common exercise and women can take the infant with them on walks. Women who exercise with a friend are more likely to fit into their schedules. Counseling about sexual activity. People may have concerns about resuming sexual intercourse and contraceptive choices. Some couples will ask questions. For others, the nurses should be sensitive to unasked questions and provide anticipatory guidance. Many new parents are reluctant to ask about when to resume sexual activity and potential changes in sexuality resulting from pregnancy and childbirth. Fatigue, pain, fear of pregnancy, concerns about a baby, and a feeling of unattractiveness may interfere with a woman's sexual desire. Some women who breastfeed have nipple tenderness and should be advised that this should subside after the first week and that ongoing nipple pain is not normal. Couples usually can begin intercourse as early as 2 weeks after giving birth, if desire and comfort allow. Low estrogen levels during the early postpartum period and during lactation cause vaginal dryness. Application of a water-soluble vaginal lubricant may increase comfort during intercourse. Women with third or fourth degree lacerations or episiotomies may need more time for healing to be complete. Cultural or religious convictions may restrict the choices of contraceptive method for some couples. Availability of healthcare or limited finances may dictate the choice for others. Discuss previous experience with contraceptives and the satisfaction with those methods. Instructions about follow-up appointments. Remind the new mother to make an appointment with her provider for a postpartum examination at the time suggested. This is often 4 to 6 weeks after vaginal birth and 2 weeks after cesarean birth. Emphasize the importance of the postpartum examination. It allows early assessment of postpartum healing and identification and treatment of problems that may develop. It also provides an opportunity for contraceptive counseling and planning for future pregnancies. Women who have had complications during the pregnancy or postpartum period may need to see their healthcare provider sooner or have more extensive follow-up than those without these complications. Teaching about signs and symptoms that should be reported. Teach new mothers and at least one family member which physical signs and symptoms should be reported to the healthcare provider immediately. These include the following: fever, localized area of redness, swelling, or pain in either breast, persistent abdominal tenderness, feelings of pelvic fullness or pelvic pressure, persistent perineal pain, frequency, urgency, or burning on urination, abnormal change in character of lochia, increased amount, resumption of bright red color, passage of clots, foul odor, localized tenderness, redness, edema, or warmth of the legs, redness, separation, or edema of, or foul drainage from, an abdominal incision. Ensuring that all elements have been taught. Organize information so that it can be presented and absorbed in the time available. Many facilities have a television channel for patient teaching. If this format is used, the nurse should follow up, clarifying any misunderstandings and answering any questions. In some cases, women are given information pertaining to postpartum self-care during the prenatal period. During the hospital stay, the nurse reviews and rechecks the mother's understanding of previous teaching. Although there are many topics to discuss in parent teaching, avoid covering too much information at a time. Interspersing small segments of teaching into normal care throughout the day will keep the woman from being overwhelmed and help her remember information better. Written instructions, including a phone number for questions, should also be provided at discharge for the family's reference. Documenting teaching. Documentation is an important aspect of teaching, just as it is for other aspects of nursing care. Documentation that discharge teaching was performed and that the patient has indicated comprehension of teaching is required by accrediting agencies. To prevent omissions, many hospitals use teaching checklists to record topics that should be taught. Evaluation. The mother's demonstration of correct breast and perineal hygiene provides evidence of her ability to perform self-care measures. Her ability to discuss practices that promote health in the areas of diet, exercise, rest, and sleep confirms her understanding of these measures. Her plan for future appointments with the healthcare provider for examinations or follow-up of complications increases the likelihood that she will experience an uncomplicated recovery. Postpartum discharge and community-based care. Criteria for discharge. Most women leave the hospital when they are just beginning to recover from giving birth and starting to learn how to care for themselves and their infants. Criteria for discharge of mothers has been developed by the AAP and ACOG and include the following. The mother has no complications and assessments including vital signs, pain level, lochia, fundus, urinary output, incisions, ambulation, ability to eat and drink, and emotional status are normal. Pertinent laboratory data, including blood type and hemoglobin hematocrit, have been reviewed, and Rho-D immunoglobulin has been administered if necessary. The mother has received instructions on self-care, deviations from normal, and proper response to danger signs and symptoms. The mother demonstrates knowledge, ability, and confidence to care for herself and her baby. The mother has received instructions on postpartum activity, exercise, and relief measures for common postpartum discomforts. Arrangements have been made for postpartum follow-up care. Family members or other support persons are available to the mother for the first few days after discharge. Community-based care. Many assessments and interventions of postpartum women occur in the clinic or outpatient setting. Mothers leave the birth facility when they are not fully recovered from the childbirth experience. Parents should be made aware of local community care services, information lines, websites, telephone calls from birth facility staff, nurse-managed postpartum outpatient clinics, and in some areas, home visits provide information and guidance for postpartum families. Breastfeeding and parenting classes, baby and me walks or exercise sessions, and postpartum support groups also may be available. Psychosocial adaptations. Perhaps no other event requires such rapid change in family structure and function as the birth of a baby. The addition of a new baby requires that all family members adjust their roles. The mother progresses through restorative phases to replenish the energy lost during labor and childbirth and to gain confidence in her role as mother. Both the mother and the father continue the process of attachment with the newborn that began during pregnancy. Siblings must adapt to a new standing in the family structure. Numerous factors such as previous experience, available support system, and culture influence the family's adaptation. The role of maternity nurses includes not only the care of the mother-infant dyad, but also the well-being of the entire family. Nurses are concerned with the family's adjustment to childbearing during the hospital stay and during the early weeks at home. The first 12 weeks, as the family makes a transition to parenthood and adapts to changes in the family structure, are often called the fourth trimester. The process of becoming acquainted. Nursing literature has described how parents and newborns become acquainted and progress to develop feelings of love, concern, and deep devotion that last throughout life. The terms bonding and attachment are commonly used to describe the initial steps. Although the terms are sometimes used interchangeably, their meanings differ. Bonding. Bonding refers to the rapid initial attraction felt by parents for their infants. It is unidirectional from parent to child, and it is enhanced when parents and infants are permitted to touch and interact during the first 30 to 60 minutes after birth. During this time, the infant is in a quiet, alert state and seems to gaze directly at the parents. Infants should be placed skin to skin on the mother's chest or abdomen for bonding time immediately after delivery if possible. Nurses frequently delay procedures such as measurements and medication administration that would interfere with this time, so parents can focus on their newborn baby. Early and sustained contact between the parents and infant can enhance bonding and attachment. However, if early contact between parent and infant is limited because of an obstetric emergency or neonatal illness, bonding and attachment can still occur at a later time. Attachment. Attachment is a process by which an enduring bond between a parent and child is developed through pleasurable, satisfying interactions. The process begins in pregnancy and extends for many months after childbirth. The infant receives warmth, food, and security from the parent. The parent accepts responsibility for the infant's care and places the child's needs above his or her own for years to come. In return, the parent receives enjoyment and establishes his or her identity as a father or mother. Both infant and parent benefit from the formation of irreplaceable links that continue long after the child ceases to be dependent. Attachment follows a progressive or developmental course that changes over time. It is rarely instantaneous. Attachment behaviors of inexperienced or first-time mothers do not differ significantly from those of experienced mothers. Attachment occurs through mutually satisfying experiences. Therefore, if the newly delivered mother is in pain or physically exhausted, she needs pain relief and assistance so she is able to enjoy the early experiences with the baby. Attachment is reciprocal. It occurs in both directions, parent and infant. It is facilitated by positive feedback, either real or perceived, from the infant. For example, an infant's grasp reflex around a parent's finger means, "I love you" to the parent. Alert infants have a repertoire of responses called reciprocal attachment behaviors. Behaviors are the infant's part in the process of early attachment that progresses to lifelong mutual devotion. Reciprocal attachment behaviors. Newborn infants have the ability to do the following: make eye contact and engage in prolonged, intense mutual gazing, move their eyes and attempt to track the parent's face, grasp and hold the parent's finger, move synchronously in response to rhythms and patterns of the parent's voice, called entrainment, root, latch onto the breast, and suckle, be comforted by the parent's voice or touch. Maternal touch. Maternal behavior, particularly maternal touch, changes rapidly as the mother progresses through a discovery phase with her infant. Initially, the mother may not reach for the infant, but if the infant is placed in her arms, she holds the baby in an en-face position with the infant's face in the same vertical plane as her own so they can have eye contact. When the infant is awake, the two engage in prolonged mutual gazing. The mother needs time to get acquainted with the tiny stranger. She may gently explore the infant's face, fingers, and toes with her fingertips only. After using fingertips to explore the new infant, the mother begins to stroke the baby's chest and legs with her palm. Next, she uses her entire hand and arms to enfold the infant and to bring her baby close to her body. She holds the newborn closer, strokes the baby's hair, presses her cheek against the infant's cheek, and finally feels comfortable enough to engage in a full range of consoling behaviors. The mother next begins to identify specific features of the newborn. Look how bright his eyes are. Then she begins to relate features to family members. He has the father's chin and nose. This identification process has been called claiming or binding in. Verbal behaviors. Verbal behaviors are also important indicators of maternal attachment. Most mothers speak to the infant in a high-pitched voice. Although many mothers have been calling the baby by name since seeing it on an ultrasound scan during pregnancy, others wait until after the birth to progress from calling the baby it to he or she, and then by using the given name. I can't believe it's here rapidly becomes Michelle is such a good baby. Verbal behaviors may provide clues to a mother's early psychological relationship with her infant. Nurses observe the interactions of mothers and their infants, and if necessary, teach and model interactions that foster early attachment between them. Refer to social worker or home visit if needed to further assess bonding behaviors. The process of maternal adaptation. Puerperal phases. Rubin, 1961, identified restorative phases that mothers go through to replenish the energy lost during labor and attain comfort in their new role. The puerperal phases are called taking in, taking hold, and letting go, and provide one method to observe progressive change in maternal behavior. Although they should not be used as strict guidelines for maternal assessment, the phases can help the nurse anticipate maternal needs and intervene to meet those needs. Taking in phase. During the taking in phase, the mother is focused primarily on her own need for fluid, food, and sleep. Inexperienced nurses may be puzzled by the mother's passive dependent behavior as she takes in or receives attention and physical care. She also takes in every detail of the neonate, but seems content to allow others to make decisions. A major task for the mother during this time is to integrate her birth experience into reality. To do this, she discusses her labor and delivery many times on the telephone or for visitors. She attempts to piece together all the details from those who were involved in the birth. The process helps the mother realize that the pregnancy is over and the newborn is now a separate individual. Although Rubin believed that the taking in phase lasted for approximately 2 days, it probably lasts a day or less today. The phase may be prolonged when a cesarean birth, especially in an emergency room, has been necessary. These women may have difficulty assimilating the unfamiliar and intrusive procedures that occurred in rapid succession and may have negative perceptions of the birth experience. Women who have had cesarean births need continued attention and sensitive care that takes into account their physical and psychological needs. Taking hold phase. The mother becomes more independent during the taking hold phase. She exhibits concern about managing her own body functions and assumes responsibility for her own care. When she feels more comfortable and in control of her body, she shifts her attention to the behaviors of the infant. She compares her infants with other infants to validate wellness and wholeness. She welcomes information about the wide variety of behaviors exhibited by newborns. During the taking hold phase, the mother may verbalize anxiety about her competence as a mother. She may compare her caretaking skills unfavorably with those of the nurse. Nurses should be careful not to assume that mothering role in caring for the infant. Instead, they should encourage the mother to perform as much of the caretaking as possible. Fathers also should be encouraged to participate in caretaking as they take on a new role. Nurses should praise each attempt, even if the parent's early care is awkward. The taking hold phase, which extends over several days, has been called the teachable, reachable, referable moment. Nurses who provide home or clinic care can take advantage of this ideal time to review previously taught material and provide additional instructions and demonstrations. Letting go phase. The letting go phase is a time of relinquishment for the mother and often for the father. If this is their first child, the couple must give up their previous role as childless couple and acknowledge the loss of their more carefree lifestyle. Many mothers must also give up idealized expectations of the birth experience. For example, they may have planned to have a vaginal birth with minimal or no anesthesia, but instead required a cesarean birth. In addition, some mothers and fathers are disappointed in the size, gender, or characteristics of the infant, who does not match up with the fantasy baby of pregnancy. They must relinquish the infant of their fantasies and accept the real infant. These losses often provoke feelings of grief that are so subtle that they might be unexamined or unacknowledged. Both parents may benefit, however, if given the opportunity to discuss unexpected feelings and realize these feelings are common. If the mother is very young or the pregnancy was unplanned, the feelings of loss and grief may be acute. During this phase, the mother refocuses on her relationship with her partner. She also may return to work at this time. This requires relinquishing part of the care of the infant to a caretaker. Maternal role attainment and role conflict. Role attainment is a process by which the mother achieves confidence in her ability to care for her infant and becomes comfortable with her identity as a mother. The process begins during pregnancy and continues for several months after childbirth. The transition to the maternal or paternal role includes the following 4 stages. 1. The anticipatory stage begins during the pregnancy when the pregnant woman chooses a physician or nurse midwife and a location for the infant's birth. She may attend childbirth classes to be prepared and feel she has some control over the birth experience. She seeks out role models to help her learn the mother role. 2. The formal stage begins with the birth of the infant and continues for approximately 4 to 6 weeks. During this stage, behaviors are largely guided by others, such as health professionals, close friends, and parents. A major task during this stage is for parents to become acquainted with the infants so that the parents can mesh their caregiving with infant cues. 3. The informal stage, which may overlap the formal stage, begins when mothers have learned appropriate responses to their infants' cues and signals. The mothers begin to respond according to the unique needs of their infants and develop the maternal role that fits them rather than following textbooks or health professionals' directives. 4. The personal stage is attained when the mother feels a sense of harmony in the role, enjoys the infant, sees the infant as a central person in her life, has internalized the parental role. The mother accepts the role of parent and feels comfortable in this role. The range of time for achieving the maternal role is highly variable, some mothers reaching that point in the first month and others taking much longer. Maternal role attainment implies an end point when the woman adjusts to motherhood. However, the process could better be called becoming a mother because it continues throughout motherhood. The mothering role grows and evolves as the mother responds to the challenges of her child's growth and development. Most mothers do not feel competent and self-confident in the mothering role till about 4 months after childbirth. Role conflict occurs when a person's perception of role responsibilities differs significantly from reality. For example, if the mother perceives her responsibility as providing most of the care and comfort for the infant, but reality dictates that she must place the infant with a caregiver and return to full-time employment, role conflict may occur. In the United States, 64% of women with children under 6 years of age and 58% of mothers with infants younger than 1 year were employed in 2015. The amount of maternity leave, now often called parental or family leave, may vary. In the United States, the Family and Medical Leave Act entitles most workers to up to 12 weeks of unpaid leave for birth or adoption. Most other countries offer paid maternity leave for 14 weeks up to a year or more to care for the new child. Many mothers feel guilty and experience intense separation grief when they first leave the infant with a caregiver. Some report feeling jealous of the caregiver, whom they fear will supplant them in the infant's affection. The nurse can help by acknowledging these feelings and reassuring the mother that her emotions are normal. Anticipatory guidance from the nurse is important. The mother needs to plan for time to reestablish feelings of closeness when she comes home from work. She needs to develop a schedule that allows maximum time with the infant when she is at home. She may have to negotiate with another family member to take over some of the household tasks until she feels more comfortable with the situation. Major maternal concerns. As a mother gains confidence in her ability to care for the infant and her physical discomfort decreases, emotional concerns related to the self become more important. Body image and the experience of postpartum blues are particularly important. Body image. Women are very concerned about regaining their normal figures. Some mothers have unrealistic expectations about weight loss and the time it takes for the body to regain its non-pregnant shape. Nurses should emphasize that weight loss should be gradual. Rigid restriction of calories can lead to depleted energy and decreased immunity. In addition, nurses should teach the importance of safe activities such as walking and graduated exercises to regain muscle tone. Some birth facilities offer classes for postpartum mothers that include exercise and nutrition, as well as the opportunity to share concerns with other postpartum women. Smoking. Some women give up smoking during pregnancy to protect the health of the fetus. However, the majority of women resume smoking at some point during the first 6 months postpartum. Factors that increase the likelihood of relapse include weight concerns, failure to breastfeed, depression, living with a smoker, stress, and planning to quit only during the pregnancy. Nurses should discuss smoking with postpartum women to offer resources for those who stop smoking prenatally and are at risk for relapse in the postpartum period. Explanations of the hazards to the infant from smoking also may be helpful because some mothers may think harmful effects only occur during pregnancy. Exposure to secondhand smoke increases the risk for sudden infant death syndrome and have been associated with cognitive impairments, behavior problems, ear infections, asthma, and other respiratory problems in children. Cigarettes themselves present a poisoning risk for small children. The amount of nicotine in just one cigarette butt is enough to poison a child. In addition, children of smokers are more likely to grow up to become smokers themselves. There are many reasons to quit smoking after the baby is born. Nurses can provide support for smoking cessation, reducing smoking, and avoiding environmental tobacco smoke and nicotine exposure around the baby. Provide encouragement and information. Refer patients to quit-line support groups and their primary healthcare provider for further assistance. Postpartum blues. Baby blues, or maternity blues, is a frequent concern for new mothers. This mild transient condition affects 60 to 80% of women who have given birth. The condition begins in the first week, peaks around 5 days, and ends within 2 weeks. If it lasts beyond 2 weeks, it may be a more serious condition. Postpartum blues is characterized by irritability, fatigue, tearfulness, mood swings, and anxiety. The symptoms are usually unrelated to events, and the condition does not seriously affect the mother's ability to care for the infant. Nurses should prepare women and their family members for the occurrence of postpartum blues symptoms, let them know it is normal, and offer emotional support and encouragement. Explain the difference between the transient postpartum blues and more serious postpartum depression and anxiety that may require treatment. Although the direct cause is unknown, postpartum blues may be a result of the emotional letdown that occurs after birth, postpartum discomfort, sleep deprivation, anxiety, and her ability to care for the infant, and body image concern. Hormonal fluctuations have not been provided to be a cause, but associations with thyroid dysfunction, serotonin, and progesterone levels have been suggested. Although postpartum blues is self-limiting, mothers benefit greatly when empathy and support are freely given by the family and the healthcare team. Because the condition is so common in postpartum women, caregivers or family members may not be as empathetic as they would be for a condition deemed more serious. Yet the mother needs adequate attention to move through this period. She should be encouraged to rest, take time for herself, and discuss her feelings. In addition, reassurance should be given that such feelings are normal and generally last less than 2 weeks. Postpartum blues should be distinguished from postpartum depression and postpartum psychosis, which are disabling conditions and require therapeutic management and full recovery. Screening for risk factors, e.g., previous history of depression or mental illness or limited social support, along with initial screening and education about early warning signs and symptoms, is important during the birth facility stay. Many hospitals conduct a baseline Edinburgh postnatal depression screen before discharge. Nurses should teach the woman and the family to call a healthcare provider if depression becomes severe or lasts longer than 2 weeks, or if she is unable to cope with daily life. Early detection and early intervention improve treatment success. Nurse home visits, parenting support groups, talk therapy, or medication can be options for treating postpartum depression. Process of family adaptation. Birth of an infant requires a reorganization of roles and relationships within the family. Previously childless couple now must integrate a new member into the family unit. Fathers or partners must learn new skills and often adjust to new roles. Siblings must adapt to a new standing in the family structure. Expectations and involvement of grandparents vary widely. Each family member is affected. Fathers. Father's developing bond with the newborn is facilitated by engrossment. Engrossment is an intense fascination and face-to-face observation between the parent and newborn. It's characterized by the father's intense interest in how the infant looks, responds, and a desire to touch and hold the baby. Many parents comment on the baby's distinctive features and view the baby as perfect. They experience strong attraction to the infant and elation after the birth. Father's attachment behaviors increase when the infant is awake, makes eye contact, and responds to the father's voice. Many fathers eagerly look forward to co-parenting with their mate. However, they may lack confidence in providing infant care and are sensitive to being left out of instructions and demonstrations of infant care. They may feel that others expect them only to provide support to the mother. Nurses can assist fathers by involving them in childcare activities soon after birth to help them feel more confident and competent. Although first-time fathers may attend prenatal classes about parenting, they often do not know what to expect from infants and need more information about normal growth and development during infancy. A review of information about childcare presented in the prenatal period is helpful after the baby is born, when the information seems more relevant and the father is ready to learn. The additional work involved in care of a newborn may be a source of concern for both mothers and their partners. Parents should be encouraged to negotiate the division of household chores during pregnancy or shortly after delivery. Siblings. Siblings' response to the birth of a new brother or sister depends on their age and developmental level. Toddlers usually are not completely aware of the impending birth. When the baby arrives, they may view the infant as competition and fear they will be replaced in the parent's affection. They may have feelings of jealousy and resentment when they must share time and attention with the baby. Some toddlers exhibit hostile behaviors towards the mother, particularly when she holds or feeds a newborn. Sleep problems, an increase in attention-seeking efforts, and regression to more infantile behaviors such as renewed bedwetting and thumb-sucking are common. These behaviors show the jealousy and frustration young children feel as they observe the mother's attention being given to another. Parents can be taught to accept without judgment the strong feelings expressed by the toddler and to continue to reinforce the child's feelings of being loved. Plans for change in routine, such as beginning toilet training, should be postponed until family adjustments have been made. Expecting 2-year-olds to welcome a stranger is not realistic until they feel secure in the affection of their parents. Preschool siblings may engage in more looking than touching. Most spend at least some time in proximity to the infant and talk to the mother about the infant. Older children may adapt more easily. All siblings need extra attention from the parents and reassurance that they are loved and important. Sibling classes, available in many agencies, may help ease the transition. Siblings are often allowed to visit the mother on the postpartum unit, where they can interact with the new baby. At home, a relaxed approach without time constraints may facilitate interactions between young children and infants. Special care should be taken by the parents, visitors, and nurses to pay as much attention to the siblings as to the new baby. Parents can emphasize the advantages of being an older sibling and allow siblings to participate in age-appropriate aspects of infant care. Grandparents. The involvement of grandparents with grandchildren depends on many factors. One of the most important is proximity. Grandparents who live near the child frequently develop a strong attachment. This evolves into unconditional love and a special relationship that brings joy to the grandparents and an added sense of security to the grandchildren. When grandparents live many miles from grandchildren, have sporadic contact, forming a close attachment is more difficult. Grandparents may try to devise ways to foster a relationship with grandchildren they seldom see. Expectations of the role of grandparents are also a factor in their adaptation to the birth